So let's discuss some explain why type questions on the chapter anti-diabetic drugs. So the first question is, regular insulin is the only insulin used intravenously. So we know that normally insulin is taken subcutaneously, and insulin is of different types like short acting, intermediate acting, longer acting. So regular insulin is the only insulin used intravenously. What is the reason? Unlike other insulins which come as suspensions, which are formulated as suspensions, regular insulin is an unmodified clear aqueous solution. Whereas other insulins, they are suspensions. Like mean that suspensions mean particulate matter by adding zinc or protamine, like in NPH or lente. So what happens if, for example, if NPH is given intravenously, what will happen? It will cause severe microembolisms. Microembolisms in the circulation. But regular insulin, as it is not a suspension, it can be given intravenously. That is the reason regular insulin is used in diabetic ketoacidosis. Other thing is that not only regular insulin is a clear aqueous solution. The ultra short acting insulins like Lispro, Aspart, they are also clear solutions, but regular insulin is cheaper and it is universally used for IV administration. Let's move to question number 2. Insulin glargine must not be mixed with other insulins. So the answer is this insulin glargine has a pH of around 4. The glargine, when injected subcutaneously, the body's neutral tissue pH neutralizes the acidic solution, causing it to microprecipitate and release slowly over 24 hours. Thus, it has a peakless background effect. If glargine is mixed in the same syringe with other insulins, which are neutral, this precipitate, like for example regular insulin, it will precipitate inside the syringe before injection. So this premature neutralization in the syringe, which makes glargine precipitate instantly, it will alter the absorption of both the insulins. That's why glargine must not be mixed with other insulins. Let's move to question number 3. Beta blockers can mask insulin-induced hypoglycemia. So first you have to know what happens when hypoglycemia occurs. When hypoglycemia, for here it is insulin-induced hypoglycemia. So if there is an insulin overdose, which may lead to hypoglycemia, when it occurs, brain senses this low glucose and brain triggers sympathetic discharge, that is epinephrine release. This epinephrine binds to beta-1 receptors on heart, leading to palpitations and tachycardia, and beta-2 receptors on the muscles, skeletal muscles, leading to tremors. Also sweating, but that is acetylcholine mediated. So if beta blockers are administered, it will block those beta receptors. So there will be no signs of hypoglycemia. The symptoms of hypoglycemia will not be there because the receptors are blocked. There will be no tremor, there will be no palpitation, there will be no tachycardia. But an exception is there, sweating will be there because sweating is acetylcholine mediated. So that's why beta blockers can mask insulin-induced hypoglycemia. Question number 4. Soluble or crystalline insulin is preferred for diabetic ketoacidosis. So what happens in diabetic ketoacidosis? Diabetic ketoacidosis is a life-threatening emergency characterized by severe dehydration, acidosis, and peripheral circulatory failure, that is shock. So in a serious situation like this, if we administered subcutaneous insulin, the patient in diabetic ketoacidosis is severely dehydrated, I just told you, with peripheral vasoconstriction. So injecting any insulin subcutaneously will result in poor, unpredictable absorption, and we can't afford that. So IV route is preferred. IV not preferred, IV route is required. It's a must requirement. That's why regular insulin is administered. I just discussed in question number 1 why regular insulin is used intravenously. So this is the reason. This question comes very often. The management of diabetic ketoacidosis. Next question, furosemide, corticosteroids, and OCPs are oral contraceptive pills, may have a blunt effect on insulin. So, what happens? First, furosemide. So, furosemide causes potassium depletion. Furosemide is a diuretic. It's a loop diuretic. Furosemide acts on the receptor. Acts on the sodium potassium 2 chloride channels, leading to diuresis. So, furosemide causes hypokalemia as well. It's a side effect. Causes potassium depletion. And we know that intracellular potassium is required for proper insulin secretion from the pancreatic beta cells. So, furosemide causes hypokalemia, decreases insulin secretion. It also directly decreases tissue sensitivity to insulin, kind of insulin resistance it causes. So that is the reason for furosemide. Then corticosteroids. Corticosteroids increase gluconeogenesis in the liver and decrease peripheral glucose utilization in skeletal muscle. That means it induces insulin resistance. This is the reason for corticosteroids. And OCPs, progestins, and to a lesser extent estrogens, which are components of OCPs, can induce peripheral insulin resistance and alter carbohydrate metabolism, requiring a dose increase for diabetic patients. So all three of them have a property of inducing insulin resistance. That's why they may have a blunt effect on insulin. Metformin is contraindicated in renal failure. So metformin doesn't undergo hepatic biotransformation, hepatic metabolism. It is secreted, renal tubular secretion. It is excreted through the kidney, unchanged form. So now what happens when there is a renal failure? There will be a decreased excretion of metformin. Metformin will be the metformin concentration will be increased in the blood, leading to metformin toxicity. And what does metformin do? Metformin causes anaerobic glycolysis, leading to the production of lactic acid. But in normal conditions, when kidneys are working fine, this lactic acid which is produced is when it is produced, liver takes care of it. Liver clears it. But in case of renal failure, as there is a toxicity occurs of metformin, so there is very increased amount of excessive amount of lactic acid is produced, and liver cannot clear that much amount of lactic acid, leading to lactic acidosis, which can lead to coma or death. That's why metformin is contraindicated in renal failure. Question number 7: metformin should not be combined with cimetidine or furosemide. This question also has to do with the excretion of metformin through urine via renal tubular excretion. So metformin requires one transporter, organic cation transporter, OCT, and furosemide and cimetidine, they also require a transporter for the secretion. So there will be a competition. We can understand there will be a competition that will lead to decreased excretion of metformin and increased concentration of metformin in the blood, leading to metformin toxicity, and everything is the same as question number 6. Then question number 8: pioglitazone is avoided in chronic hepatic failure or liver disease. So CHF is chronic heart failure or liver disease. So what happens? This is a very important contraindication, very important. Pioglitazone, what does this drug do? What is this mechanism of action? It is a PPAR gamma activate. It activates PPAR gamma activator agonist. It regulates gene transcription for lipid and glucose metabolism. So, but this PPAR gamma is also present in renal tubular epithelial cells. So when pioglitazone activates these PPAR gamma, it will lead to increase in the expression of epithelial sodium channels, leading to renal sodium absorption, and osmotically water also will be absorbed. That will lead to plasma volume expansion, and that will lead to increased venous return. That is a preload. So it will precipitate or worsen chronic heart failure. That's the reason it is avoided in chronic heart failure. And what is the reason it is avoided in liver failure? This is when these PPAR gamma agonists were introduced in the market. The first drug that was there was troglitazone, which was withdrawn due to severe fatal idiosyncratic hepatotoxicity. But pioglitazone is much safer than troglitazone, but it still carries a risk of liver injury. That's why liver function tests or LFTs must be done before starting pioglitazone and periodically thereafter. This is the reason why pioglitazone is avoided in chronic heart failure or liver disease. Let's move to question number 9. Combining glitazones with insulin is discouraged. So we know insulin is an anabolic hormone. It causes weight gain, and Insulin also causes mild salt and water retention. Glitazones, I just told you the mechanism of action, how they cause water and fluid retention. Insulin also causing water and fluid retention. So there will be their net effect will be a severe increase in the venous return. So if the patient is suffering from chronic heart failure, it will precipitate that. That is first reason. Second reason is insulin is an anabolic hormone, and these glitazones, they also increase the subcutaneous fat. So the net effect is massive weight gain. So these are the main two reasons why glitazones and insulin, they combine. We don't combine glitazone and insulin. So let's move to question number 10. Question number 10, question number 11, question number 12 are very important. And these, the question number 10, what it says, acarbose commonly causes flatulence and GI discomfort. So what is acarbose? Acarbose is an alpha glucosidase inhibitor. What is alpha glucosidase? It is an enzyme present in the intestinal blood borders. It is not an enzyme. It is a group of enzymes like sucrase, maltase, glucoamylase. So what do these enzymes do? They cause breakdown of or cleavage of complex disaccharides and oligosaccharides into monosaccharides. So if we block that enzyme, if we inhibit that enzyme by giving acarbose, voglibose, miglitol, so what will happen? There will be no cleavage of the complex disaccharides and oligosaccharides. These unabsorbed carbohydrates will pass down into the large intestine because they are not absorbed. Colonic bacteria, there are many bacteria present in the colon. Colonic bacteria ferment these undigested carbohydrates and they produce massive amounts of intestinal gases like carbon dioxide, hydrogen, methane. It will lead to flatulence, bloating, and abdominal discomfort, and loose stools as well. That's why what we do to prevent it, we start with a very low dose and we gradually increase to minimize these side effects. And if a patient on acarbose gets hypoglycemia, what drug is used? Oral glucose, not sucrose, because sucrose is blocked. Sucrose will not be absorbed. This is also an explained by question. Very important. Let's move to SGLT2. Let's move to question number 11. SGLT2 inhibitors cause UTIs and dehydration. This can also be explained by its mechanism of action. So SGLT2. SGLT2 stands for sodium, S for sodium, Gl for glucose, and T for transporter. Transporter 2. These transporters are present where? In the proximal convoluted tubule. So if we inhibit this transporter, what this transporter actually do? It reabsorb the filtered glucose. So what will happen if we inhibit that? Urine with the filtered glucose will not be absorbed, and urine becomes highly saturated with glucose. There will be massive glycosuria, and this urine will act as an excellent nutrient-rich culture media for bacteria and fungi, leading to increased risk of UTI and vulvovaginal candidiasis and balanitis. And the next is dehydration. So if the urine is highly saturated with glucose will osmotically absorb water, that will lead to dehydration. Excessive water and sodium will be lost, and that will lead to dehydration, like volume depletion, dehydration, thirst, and potential hypotension. Some of the examples of SGLT2 inhibitors: dapagliflozin, empagliflozin, canagliflozin. These are some of the examples. Then the last question: sulfonylureas are not effective in juvenile diabetes mellitus. So what happens in juvenile diabetes mellitus? Juvenile diabetes mellitus is just another name for type 1 diabetes mellitus, and we know that type 1 diabetes mellitus is an autoimmune disease. There is autoimmune destruction of pancreatic beta cells, and that leads to absolute deficiency of insulin. No functional beta cells remain in the pancreas, and you have to know the mechanism of action of sulfonylureas. Sulfonylureas are insulin secretagogues. So what happens? The mechanism of action: sulfonylureas bind to sulfonylurea receptor 1 (SUR1) on the surface of intact beta cells, and it blocks ATP sensitive potassium channels on the beta cells. That leads to depolarization. The potassium channels are blocked, that will lead to depolarization, and this depolarization causes calcium influx, and thus it leads to insulin degranulation, maybe increased insulin release. But for this whole thing to happen, we need beta cells. We need functioning beta cells for that. For this whole thing to happen, we need beta cells which are functioning. But in case of juvenile diabetes mellitus or type 1 diabetes mellitus, there is no functioning beta cells present at all. So where will the sulfonylureas act, and where will this how will they increase the secretion of insulin? They will not be able to act because there are no beta cells. So that's why they are not effective. What do we use? We use exogenous insulin. Subcutaneous insulin is the drug of choice in case of type 1 diabetes mellitus. That's why it is also known as insulin-dependent diabetes mellitus, because it is insulin-dependent. You can't treat type 1 diabetes mellitus with oral hypoglycemic agents.